जाऊ नको रे राधिका. अरे नको रे, अजून ती ऐश्वर्या पण मला मग हैराण करायला सुरुवात करते रे.
Good evening, everyone. Learning is a matter of gathering knowledge. Wisdom is apply that knowledge. On this auspicious day of Ram Navami, I, Dr. Grivita Raikar, co-chairperson MahaAP Women's Committee, welcome you all for the fourth session of Wednesday Wisdom. The theme for today is neurology, in which we will be primarily covering headache and encephalitis. On the outskirts, I welcome Dr. Ram Gopal Chejera, sir, President, MahaAP. Sir, your take on this.
Okay.
Welcome.
Thank you, Grevita. Welcome everyone and good evening and happy Ram Navami to everyone. I appreciate actually the efforts taken by our women committee chairperson Dr. Manjusha and co-chairperson Dr. Grevita. They are doing wonderful job. Again, a complex topic of headache and encephalitis, but they have taken the efforts to go through the slides of each and every presenter and correct them. So thank you, madam. And I welcome our experts, Dr. Anand Diwan and Dr. Chandana Bhagwat. Welcome. And welcome to all the presenters. I think I will not take much time. Over to Grevita. We want to start the session as early as possible. Already 170 people. That shows the success of the program.
Thank you, sir. I also welcome Dr. Amol Pawar, sir, Secretary General, MahaAP. Sir, your few words of wisdom.
Thank you. Thank you, Dr. Grivita ma'am. Yourself and Dr. Manju ma'am as a lead, as a office bearers of MahaAP Women Committee, along with Dr. Amruta as a convener and all the zonal EBs from Maharashtra. They are doing wonderful job, and almost in all sessions, the attendance was more than 300, 400 like that, and all the topics which are very much informative, and the young speakers from entire Maharashtra, they are doing wonderful job under the guidance of various experts in each time. And this time, I must thank Dr. Anand Diwan sir, who is from my hometown, Nasik. He consented to be an expert, and he has guided all the speakers under him, and also Dr. Chandana Bhagwat ma'am, who is from Navi Mumbai, and she has also taken time and lot of effort in guiding the speakers. The speakers, Dr. Suhas, Dr. Sachin, Dr. Pravalika ma'am, then Dr. Sachi, and Dr. Pooja ma'am from Aurangabad. They have done wonderful job, and we are very much eager to listen to them. So I wish all the best to all the speakers, and once again thank both the experts and wish the delegates a happy learning. Over to you, Grivita.
Thank you, sir. This session would not have been possible without the support of our chairperson, who is Manjusha Cherkar madam, who has taken a lot of efforts today. Manjusha ma'am, a few words of wisdom.
Good evening, all respected dignitaries on board in this auspicious gathering of fourth episode of Wednesday Wisdom of year 2024. सर्वप्रथम आपण सर्वांना रामनवमीच्या खूप खूप शुभेच्छा. On behalf of Maharashtra Academy of Pediatrics and Maharashtra Academy of Pediatrics Women Committee, I, Dr. Manjusha Sherkar, Women Committee Chairman, welcome today's expert judges, Dr. Anand Diwan sir and Dr. Chandana Bhagwat ma'am. We welcome MMC Observer Dr. Prashant Badane sir, all Central EB State IIP dignitaries, as well all the attendees on Zoom and YouTube as well. On behalf of Women Committee, I extend our gratitude towards our visionary president, Dr. Ram Gopal Chejera sir, and dynamic Secretary General, Central IIP EB, Dr. Amol Pawar sir, for giving us an opportunity to host this program. And thanks both of you for your fine guidance and rock support. We are grateful to Dr. Bhavesh Mithia sir for his scientific chair for this session. I sincerely thanks my co-chairperson Dr. Grivita Raikar for your wholehearted support and Dr. Jayashree Deshpande ma'am for moderating this program along with Dr. Grivita. Dr. Amruta Baviskar as Women Committee Chairman and all the 10 Zonal Women Committee EBs for their consistent support in organizing this roller coaster ride of selecting multiple speakers from all over Maharashtra and guiding them till date. Dear friends, you all know very well, still I like to mention that for those who have joined for today's program for the first time in this event is that we select 5 young talented speakers from all 5 zones of Maharashtra and they prepare their presentations on theme-based topics allotted to them. And speakers are guided, as Dr. Amol sir said, by our expert faculties in the same field. Topic of today's discussion is based on pediatric neurology, and today's our young, dynamic, talented speakers are Dr. Suhas Kharche from IIP Navi Mumbai, Dr. Sachin Bhandari from IIP Satara, Dr. Pravalika Ita from Loni IIP Sangamner, Dr. Pooja Totla from my own hometown IIP Aurangabad, Dr. Sanchi Rastogi from IIP Nagpur. Wish all the best to everyone. Friends, I'm sure we all will be benefited with today's scientific discussion on neurology, and it will be helpful for us in the clinical journey of rendering child services in future. I wish happy learning to all the attending friends. And friends, MMC has granted 1 MMC point. So I request every delegate to write their name, place, IIP number, and MMC registration number to get 1 MMC point also. I welcome Dr. Jitendra Gawane sir, our CIP EB, for gracing the occasion. Welcome, sir. And over to you, Dr. Grivita. Thank you. Thank you.
Thank you, ma'am. Moving further, it gives me immense pleasure to introduce our experts here. Dr. Anand Diwan sir. Sir is a consultant neurologist, Narayani Hospital, Nasik.
A quick comment from Dr. Jitendra Gawane sir, Executive Board Member from MMR region.
Ha, sir.
Please.
Dr. Jitendra Gawane sir.
Yes, Dr. Jitendra Gawane sir.
Thank you. I think without any wasting time, this today's topic very well chosen in practical aspect like headache in children, when to investigate, what to investigate. At the same time, the admitted patients like encephalitis and encephalopathy we are going to discuss. So I'm very eager to learn from the experts, and today I have my 2 colleagues in the panel, so I was very eager to listen to them, Suhas and Chandana. Yeah, thank you.
Thank you, sir. So let me introduce our experts for today. Dr. Anand Diwan sir. Sir is a consultant neurologist, Narayani Hospital, Nashik, and Dr. VM Medical College, Nasik. Also welcome Dr. Chandana Bhagwat. Madam is a consultant pediatric neurologist, assistant professor in charge pediatric neurology at MGM College, Medical College, Navi Mumbai, consultant pediatric neurologist, Kokila Ben Dhirubhai Ambani Hospital, MGM Hospital Vashi, Yevle Hospital Vashi, and Colors Hospital Kharghar. Welcome, sir and ma'am. Moving further, I welcome Dr. Suhas Kharche sir to take over now. The first topic being headache in children, approach to evaluation. Over to you, Suhas sir.
Thank you, madam.
Yeah. May you please start sharing your screen?
Yes. So good evening, everyone. I'm Dr. Suhas Kharche. I'm here to discuss approach to headache and evaluation. Headache is the most common symptom encountered in OPD practice on day-to-day basis. The prevalence of headache in pediatric population is something around 30 to 40%, and 30% of the pediatric population in some point of time suffer from recurrent headache. Most common headaches are migraine, followed by second common is tension type headache, and then medication overuse headache. Now, there are certain patterns of headache. It is very important to recognize these patterns of headache because these patterns of headache gives us clue to the etiology of headache. There are 5 temporal patterns. First is acute headache. that is a single episode of head pain without history of previous event. The possible etiology is infectious, such as upper respiratory infection, sinusitis, or intracranial pathology like subarachnoid hemorrhage, stroke, or hypertension. Second pattern is acute recurrent headache. This is a pattern of head pain separated by symptom-free interval. This is typically seen in migraine, tension type headache, and cluster headache. Then third is chronic progressive headache. This is when headache keeps on increasing in frequency and severity. This is seen in in chronically progressive disorders of the CNS, such as CNS neoplasm, brain abscess, hydrocephalus, and chronic meningitis. Chronic non-progressive headache is when headache is constant but frequent. It is seen in chronic migraine, chronic tension type headache, medication overuse headache. And then mixed headache is acute on chronic headache, which is seen in primary headache disorder when it is superimposed to a secondary cause. Now we know headache has a very vast etiology, right from simple viral infection to a brain neoplasm can give rise to headache. So international classification of headache disorder has categorized headache into three main categories. First is primary headache, which include disorders which are because of the affection of the pain modulating system, which include migraine, tension type headache, trigeminal autonomic cephalgias, and other primary headache. Secondary headache are due to affection of the pain sensitive structures of the brain. They are because of the trauma to the head and neck region. They may be attributed to vascular disorders affecting the vessels of cranial and cervical region. Some non-vascular intracranial disorders such as space occupying lesion, infective pathologies such as meningitis, meningoencephalitis, disorders of homeostasis such as hemophilia causing intracranial bleed. Some psychiatric disorders also causes secondary headache. And third main category is neuropathic or facial pain, which are due to affection of the nerve fibers. Most commonly affected nerves are between 2nd to 7th cranial nerve and 9th cranial nerve. They present either as a painless lesion of the cranial nerves or other facial pain, or they present as other headache disorder. So history taking is very important in evaluating headache. The importance of history taking can never be overemphasized. There are certain history which are very significant. One should try ask age of onset. Migraine frequently begins in the first decade. Chronic non-progressive headache, especially found in adolescent age group. Mode of onset: abrupt, sudden, severe headache, also called as a thunderclap headache, which is seen in intracranial hemorrhage. How many episodes of headache per day are there should also be asked. Such migraine typically present 2 to 4 times in a month, and never daily. If it is a daily headache, migraine is ruled out. Chronic headache present 5 to 7 times in a week, and cluster headache present 2 to 3 times in a day for several months. Duration of episode is also important. Migraine typically lasts for 2 to 3 hours. Tension type headache is variable duration. It may last throughout the day also. And cluster headache lasts for 5 to 60 minutes. Aura, if it is the presence of aura suggests migraine. Aura can be visual aura or auditory aura. Headache quality is also very much important. Throbbing or pulsating headache suggests migraine. Squeezing or pressure headache with waxing and waning pattern is suggestive of chronic non-progressive headache. Cluster headache present as a continuous pain. Location of the pain. For example, occipital location of pain suggests basilar migraine or posterior fossa neoplasm. Cluster headache typically present as a retroorbital pain. And some primary pathology such as sinusitis, dental or ear pain may suggest the localization of the etiology. The occurrence of timing of headache is very important. Headache causing child to wake up from the sleep is due to intracranial or space occupying lesion. Tension type headache occurs mostly late in the day. Aggravating and relieving factors: if headache gets aggravated by recumbent position or Valsalva manner, intracranial pathology should be suspected. Migraine headache is precipitated by the triggers such as food, odor, bright light, sleep, or exercise. Tension type headache usually worsens on stress, loud noise, bright light, or exercise. Cluster headache worsens on lying down or resting. Relieving factors: migraine typically responds to analgesic, dark, quiet room, and sleep, and tension type headache responds to sleep, but not to analgesics. So pointers from the history: if there is associated fever with the headache, it suggests infective pathology. Weight loss suggests CNS neoplasm or tuberculosis. Neck rigidity in a probable setting suggests meningitis or meningoencephalitis. Scalp artery tenderness, if we found, one should always suspect giant cell arteritis. Hypertension, renal and adrenal causes should be ruled out. Injuries such as trauma or non-accidental injury may be a cause of headache. Organomegaly, systemic causes should be considered. Bleeding or petechiae, hematological malignancy may be present. Now, as history is important, examination is also equally important, and one should start examination from basics of taking vitals. Blood pressure, heart rate, temperature, body mass index. Hypertension may be the cause of headache, or it can be also a sign of raised intracranial pressure. Fever suggests infective process. Raised BMI may suggest suspicion of pediatric idiopathic hypertension. Macrocephaly may indicate some chronic progressive disorder. Pericranial tenderness may be seen in migraine or tension type headache. Tenderness on the back of the head may suggest occipital neuralgia. Knuckle rigidity may be seen in meningitis. And bruit, if it is present anywhere, suggestive of vascular malformation. Fundoscopic examination may give typical findings of raised intracranial pressure. Altered mental status is always suggestive of intracranial pathology. Significant intracranial pathology such as raised ISP, intracranial hemorrhage, encephalitis. Dysarthric speech may indicate stroke or vascular event. Any abnormal neurological examination always suggestive of intracranial pathology. Skin examination is very important because neurocutaneous markers such as neurofibromatosis or tuberous sclerosis can be highly associated with intracranial tumors or vasculopathy. Rash may suggest autoimmune pathology or infectious process. Bruit may indicate trauma or bleeding disorder. Bruises may indicate trauma or bleeding disorder. And substance abuse, needle stick injuries can be found. Now, these are two most common types of headache which are found in pediatric age group. Migraine, which present in 4 stages. First stage is prodrome phase. Second is aura stage. Third is attack stage. And fourth is postdrome stage. The prodrome stage is typically characterized by constipation, mood swings, food craving, neck stiffness, and increased thirst or urination and frequent yawning. Whereas aura stage is characterized by visual phenomena like dark spots in front of the eyes, pin and needle sensation over skin, weakness or numbness of the face on one side of the body, difficulty in speaking or hearing noises. Then third stage is attack stage. It usually, attack stage is seen is a pain occurring on one side of head, usually pulsatile in quality. Nausea, vomiting may be associated, and there will be sensitivity to light. Postdrome phase is typically characterized by draining out sensation by the patient, and even the movement of head, there can be a reoccurrence of the pain. Tension type headache typically present as a bilateral pain and with a band-like feeling. It is not associated any focal neurological symptoms. It is one of the most common type of headache, and it poorly responds to analgesic. Anti-migraine drugs may be required for relief. Then third most common type of primary headache is a medication overuse headache. It occurs nearly every day, often wakes the patient early in the morning from sleep. This headache typically improves with the pain medicine, but pain reappear again once the effect of medicine starts waning off. Most common medication associated with medication overuse headache are opioid, analgesic, NSAID, caffeine, ergotamine, and triptans. Approach to headache, one should take, as we discussed, history and clinical examination, identify red flag sign. Depending on investigation, depending on history and clinical examination, investigation should be planned such as neuroimaging and CSF study. And we can classify headache into primary headache disorder and secondary headache disorder, and depending on, we can manage.
Can I interrupt Dr. Suhas? The
Yeah.
time is, you have just a minute left.
Yeah. So to identify danger sign, there is a mnemonic which is called as a Snoopy. If these Snoopy symptoms are present, it may suggest the danger, means thorough evaluation is needed. So systemic symptoms such as fever, altered sensorium, pregnancy, anticoagulation therapy, HIV infection, neurological symptoms such as any abnormal neurological findings such as papilledema, focal neurological defects, seizures, abnormal cerebral function, sudden onset such as thunderclap headache, occipital localization of pain. Then there are 4 patterns that precipitated by Valsalva mania, positional headache, progressive headache, and lack of family history of headache, and headache occurring less than 6 years. These are danger signs, red flag signs, acute onset, severe vomiting, high risk underlying condition, abnormal neurological symptoms, seizure, cerebellar sign, meningismus, and occipital headache. So investigations planned are CT brain, is generally good for trauma and intracranial bleed. MRI, neuroimaging of choice in most of the intracranial pathology, especially posterior fossa tumor, vascular pathology. If suspected, cerebral angiography is a choice of investigation. In case of infective process or CNS neoplasm, CSF examination should be done. Recurrent seizures, EEG should be planned. If there is a CSF leak, myelography is done. Thank you.
I request Dr. Anand, thank you, Suhas sir. I request Dr. Anand Diwan sir kindly give his expert comment. Dr. Anand Diwan.
Very well covered topic in
Sir, you are not clearly audible, sir.
Dr. Suhas can stop share the screen.
Yes.
very well covered topic for evaluation of headache. Am I audible?
Yes, yes.
Just to summarize, the last two slides are most important. The danger signs or the red flags, Snoopy. Whenever we come across any of these, then imaging is must. Again, the dilemma comes whether to do CT or MRI. So whenever it is non-traumatic and a stable child, always prefer MRI. Rest, if it's a history of trauma and child is not that stable, then I think CTs can to be done on an urgent basis. Again, the headaches, which are usually unilateral, classically we get it in adults, but in pediatric population, we get it bifrontal rather than unilateral headache. Again, one point for aura, I would like to say that visual auras of migraine are usually black and white. And for epilepsy, it is colorful. So just asking whether those, whatever visual flashes, visual hallucinations were black and white or colorful, we can differentiate whether it was a seizure or it was a migraine. The incidence of primary and secondary, for adults, it is almost 90% are primary and 10% are secondary. But for pediatric population, I'll say it's around 40-60 or 50-50 primary and secondary. Even though it's a secondary, the causes are usually benign, like just a viral fever, URTI, dental caries, something like that, and not really meningitis or other. While rest of 50% primary headaches, majority are again migrainous headaches. In examination, two most important points are checking the blood pressure and checking the fundus. No child with headache should go without checking the blood pressure and fundus. It is, I will say, it's a crime not seeing these two findings at least in each and every child coming to the migraine. And majority of the times, the child may not come or the parents may not complain of the headache, but the other migraine variant in pediatric population is equally important. Usually we come to the diagnosis of migraine variant when we get a history of migrainous headaches in parents. So those are usually just episodic vertigo. We call it as a benign paroxysmal vertigo. Sometimes cyclical vomiting or just abdominal recurrent pain when all investigations are negative and it's like a diagnosis of exclusion. So these three variants are to be kept in mind in a pediatric population. The red flags is equally important in each and every child. That concludes my comment for this.
Thank you, sir.
Thank you.
Thank you for this clear take-home messages. Moving further, I request Dr. Sachin Bhandari from IIT Satara to come up with the next topic on headache in children management. You may start, Dr. Sachin. Your slides are visible.
Dr. Sachin can start. Your slides are there.
Sachin sir, try now. Sachin sir, try now.
Yeah.
Yes. Okay.
Your
evening,
video
everybody.
isn't-
Good evening.
Your video isn't visible, sir. Sachin sir, your video is not visible.
Yeah. Am I visible now?
Yes.
Yeah. Good evening, everybody. After a description of approach to headache and its evaluation, now let's manage the headache in children. What are the objective for the management of headache in children? Just a second. My slide. Yeah. To identify life-threatening intracranial causes such as hemorrhage, tumor, and hydrocephalus, minimal use of analgesic drug aiming at constant response, to avoid the chronic misuse of analgesic without identifying specific cause, which itself can cause persistence of headache, to identify underlying treatable condition like sinusitis and hypertension, proper use of drug in migraine to reduce school absenteeism and to improve the quality of life and social interaction. Indication for neuroimaging is already been discussed by Suhas Kachre sir, and approach to the headache as also discussed by Suhas Kachre sir. But I just wanted to give a brief outline that headache should be divided into acute, which is lasting for 4 weeks, and subacute or chronic, which lasts for 4 to 12 weeks, and in which you have to identify the life-threatening condition, as well as you have to find it out the chronic, non-progressive, and recurrence of the headache, which are migraine and this. Acute management of the headache in an emergency room. The children with first and worst headache may come to the emergency room. Very rarely, child may present with bradycardia, altered sensorium, or features of brainstem herniation, such as dilated pupil, posturing, and bradypnea. Life-threatening situations should be identified and aggressive management should be initiated. Assessment and stabilization of airway. Support of airway, breathing, and circulation may need to be done in emergency room and in PICU later on. Urgent in-house CT preferred than MRI, because this CT will give more information of intracranial hemorrhage and skull abnormality. After ruling out the intracranial bleed, SOL, acute hydrocephalus, and meningoencephalitis, management can be less aggressive. Immediate pain relief should be done by using paracetamol, either oral, rectal, or IV, which is depend upon the child compliance. In presence of migraine, the ibuprofen 10 mg per kg per dose is found to be better choice and superior to the paracetamol. Other supportive management, in addition to pain relief, IV fluids may be used to abort the migraine attack, as inadequate hydration is known to trigger the headache. Treatment of underlying cause like hypertension should be managed by oral or sublingual nifedipine. Secondary headache due to viral infection should be managed symptomatically. Acute meningoencephalitis, which are presented with fever and signs of raised intracranial tension. Subacute or chronic headache associated with unsteadiness, visual disturbances, or abnormal eye movement, or lower cranial nerve palsy and papular edema. All these are suggestive of an space occupying lesion and which need to be operated by neurosurgeon. Now the remaining migraine, cluster headache, tension headache should be managed in following way. The acute treatment aimed for a pain relief should be managed in depending upon the severity and response to the drug. Prevention of migraine will be a second most important point, and biofeedback techniques are the third point while treating the migraine. The drugs which are used for acute pain relief should be NSAIDs, and it should be a sequential approach. Ibuprofen 7.5 to 10 mg per kg per dose should be used, and goal should be to relieve the pain in 1 hour, and child should return its normal activity within that period. The paracetamol should be used in a 15 mg per kg per dose, and limit the use of paracetamol not more than 2 to 3 times a day and not more than 2 to 3 times a week. Antiemetic and hydration of the child with oral or IV fluid is important part, and naproxen is then another NSAIDs which should be used in a 10 mg per kg per dose. Second, if the patient does not respond to these treatment plan, triptan group of the drug should be used in the form of amylotriptyline, which should be used in a children more than 12 years of age with a dose of 12.5 milligram. Rizatriptan should be used for children more than 6 years of age, and the dose is 5 milligram for a children less than 40 kg and 5 to 10 milligram for children more than 40 kg. And Simatriptan is another drug which should be used in the form of nasal preparation, and dose is 6 milligram per kg. Triptan has a low risk of serotonin syndrome when used along with selective serotonin receptor inhibitors, and it should be avoided to use more than 4 to 6 times a week. If both these drugs does not respond, then combination of drug like NSAIDs and triptan along with antiemetic should be preferred. Then ketorolac, prochlorperazine should be used, or third option is sodium valproate or dihydroergotamine. These drugs can be used in the beginning itself if the pain is very severe or previous steps fails. Ketorolac is approved in a children less than 2 years as a single IV or IM dose. Triptan and dihydroergotamine are contraindicated in migraine with brainstem aura or hemiplegic migraine for fear of worsening of symptoms due to vasospasm. Then preventive therapy should be initiated for those children who get the headache attack for more than one time in a week, or one severe headache which will be once in a month. And goal is to reduce its frequency by 1 to 2 or fewer in month. And these drugs should be given for 4 to 6 months and then weaned off. Flurazine is a calcium channel blocker. It should be used in a dose of 5 milligram OD and can increase to 10 milligram. And these drugs should be administered over 4 to 5 months and discontinued for 1 month. If it requires to give for more than 4 to 5 months, there should be a discontinuation of drug for 1 month in view of avoidance of toxicity or adverse effect. Second drug is amitriptyline. It should be used as an OD at night or evening dose and start with low dose to reach 1 milligram per kg per dose. The side effects are excessive sleepiness, anticholinergic effect, weight gain, and QT prolongation. Beta blocker like propranolol should be used in a dose of 10 milligram per day and increase to 10 milligram per week to maximum of 30 to 60 milligram. The adverse effects are increased incidence of depression in adolescent, contraindicated in asthma and diabetic mellitus. Anticonvulsant drugs are levetiracetam. There are limited study in children for migraine prophylaxis. Preferred for then nutraceuticals like riboflavin and coenzyme Q and butter beans. They are preferred for those who are believing in nutritional supplement. Prevention of headache can be done by alteration in the lifestyle management, reduced or altered sleep, skipping meal, dehydration, having stimulant like tea, coffee, chocolates are common triggers and they are easily avoidable. Adherence to the good habit, adequate sleep at proper time, taking regular meal in time, adequate fluid intake, regular exercise, healthy habits are important preventive strategies, and continued adherence of good habits even after resolution of headache is needed in order to prevent the relapse. Biofeedback assisted relaxation, cognitive behavior therapy should be advised. This will help child to control over headache and provide symptoms coping ability. Tension type of headache. This need to be treated if more than 10 episodes and each episode lasts for 30 minutes to 7 days. And each and every effort should be made to identify and treat the underlying cause of headache, because as a secondary headache should be wrongly labeled as a tension headache and treat accordingly. Treatment plan involves minimal use of analgesic and behavioral intervention, including relaxation and stress coping skill. No prophylactic therapy is available for tension headache. Cluster headache should be treated in the same way like migraine. So what are the take-home message? Neuroimaging should be considered after detailed history, physical examination, and neurological examination. Indication of neuroimaging includes acute worst headache without associated symptom like fever, cough, body pain, subacute or chronic headache with raised symptoms of raised intracranial tension, focal signs, and visual disturbance and ataxia. Commonest cause of chronic headache is migraine. Prompt diagnosis and treatment of migraine minimize the use of analgesic drug, improve school attendance, social interaction, and overall performance of the child. Treatment of the migraine falls in three aspects: is acute treatment to relieve the pain, which should be sequential approach, prophylactic treatment to prevent the recurrence, and biofeedback technique. Since the analgesic overuse by itself is an important cause of persistent headache, it should be encouraged. Thank you so much for patience hearing.
Thank you so much, Dr. Sachin sir. You are very well on time.
Yeah.
Over to you, Dr. Anand Diwan sir, for your expert comments.
Yeah, very well
Very
covered.
nice.
May you please stop share screen, sir?
Yeah.
Am I audible?
Yes, sir.
Yeah, Dr. Bhandari has very well covered the treatment part for the headache or migraine in such. The main therapy for migraine per se is lifestyle modification. We say the best treatment for migraine is sleep. So most of the children come with a headache, usually have some sleep disturbance. They sleep late because of the exam, because of the TV, mobiles, or some other reason. So when we just ask them to change their lifestyle, sleep early, get up early, have food at regular times, and do some exercises also, that helps a lot. And after that comes our pharmacological treatment, which is divided into acute therapy. Again, Dr. Bhandari is very well covered into the first line therapy, which is simple NSAIDs or paracetamol or the Brufen. Then second line, if first fails, then the triptans. Now the nasal sprays are also available for triptans like zolmitriptan or sumatriptan. So those are effective to control the acute attacks. Only thing I will address here is whenever a child gets headache, our job is to tell parent that use these rescue medicines, either it's NSAIDs or triptans, as early as possible, because there is a tendency to delay in giving therapy. If the child comes with a headache, then the parent will naturally say, wait for 10 minutes, 15 minutes, 1 hour. They will wait for natural. It should go down, but usually it will aggravate the headache. It will require more therapy. So once child complains of headache, as early you give the first dose of NSAIDs or triptan, it will subside immediately. If it fails, then maybe you can repeat after a few hours. Maximum 2 to 3 doses in a day you can give it. Coming to the prophylaxis, as already discussed, if attacks are frequent enough or impairing even day activities is causing abstinence from the school, then it should be tried. Again, the therapies, the one which I like most is cyproheptadine, which is available in syrup, because majority of parents will complain that the child is not eating well, and the adverse effect of cyproheptadine is it's like appetizer and causes weight gain. So indirectly that will be also taken care of. So cyproheptadine is usually my first choice for prophylaxis. We give it just 2 milligram or 4 milligram at bedtime, as it causes little sedation also, and not to continue for more than 1 or 2 months. Ideally, all prophylaxis to be given for at least 3 months of headache-free period, because the parents will give therapy for just 1 month and then they will skip the medicines, stop the prophylaxis, and again for next visit they will come that nothing has worked, no medicine has helped. In fact, they have not continued the prophylaxis for adequate period. So at least 3 months of headache period, we say. That means usually it takes 5 to 6 months for from the start of the prophylaxis therapy, and then it should be stopped if the headache subsides. Usually the prognosis is also good for pediatric migraine. It may relapse in adolescents and in females after some hormonal changes. So at that time, again, it can be taken care by the adult neurologist. Overall, it was nicely covered. Thank you. Thank you very much.
Thank you.
Much, sir. So, moving on further, now I request my co-moderator, Dr. Jayashree Deshpande, to kindly take over. Dr. Jayashree, ma'am.
Yeah, good evening and thank you, Gribita and Dr. Manjusha, madam. Dr. Pravalika is from IAP Sangamner branch and she will enlighten us on the clinical approach to encephalopathy. Dr. Pravalika?
Yes, ma'am. Yes. Good
Please
evening,
share your
everyone.
screen. Yeah.
Good evening, everyone, and thank you, Maha IAP, for giving this opportunity. Today my
Yes.
topic is clinical approach to encephalopathy. Firstly, its definition. It's a clinical syndrome which presents as a clinical
Pravalika,
syndrome
make it
of
into us. Okay. Yeah.
altered
Slideshow.
status, manifesting as a reduced consciousness or a altered cognition, behavior, or personality, with or without any focal neurological signs. And encephalopathy is mainly due to global brain insult, matlab diffuse involvement of the brain. And causes of encephalopathy, first is most common are infections, meningitis, encephalitis, or intracerebral abscess, or any systemic infections which later land into encephalopathy. Metabolic reasons like hypo or hyperglycemia, hyponatremia, uremia, hyperammonia, and lactic acidosis. And autoimmune causes like NMDA receptor antibody encephalopathy, encephalitis, and voltage gated potassium antibody encephalitis, and Hashimoto encephalopathy. Seizure related, it can be a post-ictal phase or a non-convulsive status, or it can be a part of epileptic encephalopathy. And trauma, it can be accidental or non-accidental. Toxins, exposure to any heavy metals like lead poisoning, or any drugs, whether it can be a recreational drugs or a therapeutic drugs. And hypertension, and hypoxia or ischemia, which occurs after near drowning in children, otherwise after a prolonged resuscitation. And vascular events after a stroke or a venous thrombosis. And spontaneous hemorrhage, it can be the first presentation of any underlying AV malformation. And malignancies, it can be primary CNS or any metastatic cancers. And history is very important. We need to ask the caregiver this history when the patient comes to us. And first is that the characterization of the episode, we need to ask whether the child encephalopathy is presenting as lethargy, drowsiness. It can be agitation, confusion, any speech disturbance, or abnormal movements or gait which are recent onset. And time course is very important, over what time the encephalopathy has developed. And based on this time course, there are differential diagnosis differentiated on this. Hyperacute encephalopathy developing over minutes, and acute over days, and subacute over weeks, and chronic over months. And to know the severity of the encephalopathy, we need to ask the history regarding the baseline function, like reduced intake or reduced activity, reduced refusal to feed if it is a younger child. And if there is any history of seizures, we need to ask whether it's a generalized or a focal seizure, it's a febrile or afebrile, what's the duration of seizure, and whether this is the first episode or is a recurrent episode. Recurrent episode, it can occur when this encephalopathy, when it is a part of epileptic syndromes. And associated symptoms like a fever, vomiting, and headache, it is mostly seen after a raised intracranial tension or a meningitis. We need to ask the vision abnormalities like reduced visual acuity or any ophthalmoplegia or gaze deviation defects. And it can be due to optic neuritis or a third nerve or a sixth nerve. When they are involved, vision abnormalities can occur. And we need to ask the history before the onset of encephalopathy, are there any episodes of diarrhea or URTI, because after that the viral encephalopathy can occur in some patients. And if it is an adolescent patient, we need to ask for a rash, joint pain, oral ulcers. It can be a part of autoimmune encephalitis or SLE. And the loss of weight or appetite, it can be because of TB or HIV, which causes encephalopathy later. Exposure to drug, toxins, and heavy metals, travel, and animal history. In the past medical history, we need to ask the perinatal history, whether it is significant or any NICU admissions and all, and previous epilepsy. And family and developmental. In developmental, we need to ask whether is any the developmental milestones are appropriate to age, or there any delay in attaining them, or any regression, loss of the attained milestones. And epilepsy syndromes or autoimmune disorders which are present in the family. And this is a differential diagnosis based on the time course of encephalopathy. In hyperacute, the most common causes are seizure after a trauma or a vascular event, hypoglycemia or a DKA, and drugs, and Press syndrome. Press syndrome is seen a little bit older children. And in acute conditions, it can be after an infection of a bacterial or viral, and inflammation, post-infectious, and autoimmune encephalitis. It can present either acute or a subacute presentation. And again, TB and parasitic infections can present as a subacute. And in chronic, infections due to TB and HIV, or a metabolic disorder or malignancies. And initially, after taking the history, soon after that, we need to see whether the patient is stable or not. For that, we need to take the vitals, and we have to see whether they are appropriate to age or not. And then to know the mental status of the child, normally we use the Glasgow Coma scale, and the reduced scores will be present when the child is in encephalopathy. But if it is a older children, it is good that we should also include mini mental state examination, because it involves the cognition and the language disorders also. Only Glasgow Coma scale with the score of 15 can also present as encephalopathy. That is why it is advised to include the mini mental state examination in an elder child. And ongoing seizure, we need to see and stabilize. And after that, after the basic stabilization is done, then examination, which is more mainly we focus on the CNS first. In that, to know any focal neurological deficit, we examine the cranial nerves, motor, sensory. And in eyes, we need to see whether there is a nystagmus is there, and pupils, whether they are miosis or mydriasis. And we need to see for the fundoscopy whether there are any hemorrhages in the retina or in a pale disc. And gaze abnormalities, as I said previously, it can be due to sixth or third nerve or a second nerve involvement. And abnormal movements, it can be a part of autoimmune encephalitis. And other systems should not be overlooked, because some systemic infections, secondary to systemic infections, and encephalopathy can occur. So examination of other systems should not be overlooked. And there are no fixed set of investigations to be done in an encephalopathy child. They should be tailored according to the differential diagnosis we have made earlier, based on examination and history. But basic investigations, or the first line investigations, we can say, which gives a immediate treatable clue for us. It can be, it is blood glucose, ABG, CBC, RFT, LFT, electrolytes, and ammonia. And blood culture is also important. And if these tests are unrevealing, then the next set of investigations, we can do a CSF analysis to know whether CNS infections are there. And after that, neuroimaging like CT and MRI to know any trauma, hemorrhage, or any midline shift of that child. Thank you.
Very well done, Pravalika. I would request Dr. Anand Diwan sir to give us expert comment.
Really well covered. There is nothing to add here. Maybe after next two lectures, if I have to something new to add, then I can
Okay, sir.
join
Yeah.
you back. Okay.
Yeah, and we will answer the queries which are raised in the chat box after this discussion is over. 22nd February is celebrated as Encephalitis Day all over the world. And this is to raise the awareness about the symptoms and the complications or the red flag signs which are associated with the encephalitis. Dr. Pooja Totla is from Sambhaji Nagar, and she is going to tell us about the clinical approach to encephalitis. Dr. Pooja Totla.
Visible.
Yes.
Ma'am, you are mute. Pooja ma'am, you are on mute. Kindly unmute.
Yes. Very good evening, everyone. Myself, Dr. Pooja Totla, presenting a clinical approach to encephalitis. Just as ma'am mentioned, every year we celebrate on 22nd February World Encephalitis Day to increase the awareness about encephalitis. Whenever a child presents to OPD with complaints of fever, headache, sleepiness, personality changes, or confusion, many diagnoses hits our brain. There are the differentials, but the important ones are encephalitis, encephalopathy, meningoencephalitis, meningitis. So we will see about encephalitis. Encephalitis is nothing but inflammation of the brain with clinical evidence of neurological dysfunction. While encephalopathy is, we have just seen, it is a clinical syndrome of altered mental status with reduced consciousness or altered behavior. But the signs of inflammation of brain will be absent over there. Meningoencephalitis is acute inflammatory process involving meninges and to variable extent brain tissue. One more important entity is acute encephalitis syndrome, which is nothing but fever with change in mental status, with or without new onset of seizure. We will talk more about acute encephalitis syndrome because it is a very important entity, as in India, every year thousands of people get affected by acute encephalitis syndrome. In 2005, there were 5737 cases, out of which 1344 died. And then Government of India started vaccination for Japanese encephalitis vaccine in highly affected region. And National Vector-Borne Disease Control Program started sentinel surveillance for acute encephalitis syndrome. In recent study, we can see they conducted at Uttar Pradesh, Assam and West Bengal. Now the etiology of acute encephalitis syndrome is changing after starting of Japanese encephalitis vaccination. Now the important causes they found were Japanese encephalitis vaccine was still Japanese encephalitis virus was still important cause, along with scrub typhus and dengue. Another study shows that in sporadic cases, herpes simplex virus is most common cause in adults, while varicella zoster virus is most important cause in pediatrics. Still, nationwide epidemiological data is not available. Most important differential always with encephalitis is encephalopathy. We have currently seen the encephalopathy slides also. So what are the important differentials? Headache is usually with encephalitis. Seizures, encephalitis can have both focal or generalized. Encephalopathy usually have generalized seizures. Focal signs are usually goes with encephalitis. Liver dysfunction, leukocytosis, they are common with encephalitis. In CSF, pleocytosis, that is total leukocyte count of CSF, more than 5 is seen with encephalitis and absent with encephalopathy. EEG, encephalopathy can have focal or diffuse changes. Encephalopathy usually have diffuse flowing. And MRI usually abnormal in encephalitis while normal in encephalopathy. So going more with encephalitis, what are encephalitis types? Today we are going to see encephalitis types, etiology, their pathogenesis and their clinical features. And in next presentation, we will see more about investigations and management. So what are encephalitis types? It can be diffuse or localized. It can be acute. Acute mostly infectious in nature. It can be post-infectious or paraneoplastic or idiopathic. The pattern of etiology is mostly autoimmune in nature in these post-infectious cases. It can be chronic degenerative because of slow viral infection like subacute sclerosing panencephalitis or human immunodeficiency virus encephalitis. So what are the etiological agents? Just we have seen the types. Acute is mostly infectious in nature, out of which more are viral causes like herpes simplex virus, varicella zoster virus, Japanese encephalitis virus, enterovirus, dengue, measles, Epstein-Barr, rabies, and many more. And less common are bacterial and parasites. In non-infectious etiology, it is mostly because of autoimmune phenomena, antibody mediated. So anti-NMDA antibody is commonest, and acute disseminated encephalomyelitis is also common etiology. The pathogenesis also varies as per the type and etiology. Like in infectious, it is because of direct infection of brain tissue. While in non-infectious, it is mostly because of immune-mediated response. We can see whenever there is infectious virus enters our body, it spreads either through systemic infection or through neural spread. It reaches to brain parenchyma. There leads to production of pro-inflammatory cytokines and chemokines by immune system, leading to inflammation of brain parenchyma. While in immune-mediated response, there is autoantibody production secondary to infection or idiopathic or cancer etiology, which leads to modulation of proteins in the brain, and also they causes binding to antigen in the brain, and finally leads to production of pro-inflammatory cytokines and chemokines and inflammation of brain parenchyma. Now moving to the clinical features. Usually viral encephalitis have two phases. First is prodromal phase followed by encephalitis phase. Prodromal phase is usually short, 1 to 3 days, with malaise, fever, altered sensorium, followed by encephalitis phase. Encephalitis phase can last for different duration in different patients depending on age and immune response. Some recover completely, some through post-encephalitic sequela with some deficits, and some may succumb. Whenever we see the patient, we get some clues depending on the clinical examination, and that shows the probable viral etiology. Like in herpes simplex, we get the focal encephalitis affecting the frontotemporal region of the brain. So patient mostly present with personality changes. Varicella zoster virus usually present with cerebellar ataxia. HIV and measles virus present with dementia, while extrapyramidal manifestations are seen with Japanese encephalitis and West Nile virus. Retinitis is common with cytomegalovirus. Rash is most commonly seen with measles, rubella, varicella zoster, and hand-foot-mouth disease. Enteroviruses usually show the associated symptoms like diarrhea, while respiratory tract infection are common with influenza, H1N1, and adenovirus. Parotitis with mumps. International Encephalitis Consortium case definition of encephalitis is there are three important features. One is encephalopathic feature, other two are inflammatory features and neurological feature. So whenever we say it is a case of encephalitis, encephalopathic feature is compulsory. With it, we should have at least two other features from 6 of total inflammatory and neurological feature. So the important feature is altered mental status lasting over 24 hours with no alternative cause, which is encephalopathic feature. Inflammatory features are fever more than 38 degrees Celsius within last 72 hours, CSF pleocytosis, new neuroimaging finding, EEG consistent with encephalitis. Neurological features are seizures or focal neurological signs. All the features are not present in every patient. They are variable, like fever in 75 to 80% patients, seizure in 50 to 75% patients, focal signs in 50 to 60% patients. So to diagnose a patient of encephalitis, there should be encephalopathic feature with two of inflammatory or neurological features. So this is a general approach. Whenever we see a patient with clinical feature fitting as encephalitis, we should first, what should hit to our mind about general laboratory evaluation is lumbar puncture. There are few contraindications to lumbar puncture, like focal neurological signs, presence of papilloedema, uncontrolled seizure. If they are present, then upfront imaging is required. Otherwise, we should go ahead with lumbar puncture. If our assessment requires some time, then we should start empirical acyclovir, keeping in mind the important devastating nature of herpes simplex virus. And whenever feasible, we should perform the lumbar puncture. And later on, neuroimaging. If neuroimaging show alternate diagnosis, we should treat as appropriate. If it is not showing any alternate diagnosis, then we have to start the treatment with acyclovir at least. If whenever we perform the lumbar puncture, we should send the CSF sample for PCR for herpes simplex virus. If it is positive, then we should give IV acyclovir for 14 days. And if it is negative, then we have to think of alternate microbiological diagnosis. If we get alternate diagnosis, then we have to treat as appropriate. If we don't get any other diagnosis also, then what should hit our mind? Is he really suffering from infectious encephalitis or post-infectious encephalitis? So what are the common features of post-infectious encephalitis, like autoimmune encephalitis? So they are usually subacute in onset. They have memory deficits, altered mental status, and psychiatric symptoms are more common with them. EEG also there is slow delta waves, and then we should seek the advice. So further investigations and management will be covered by in next PPT. So take home messages are: acute viral encephalitis is frequently devastating. WHO introduced a broad definition for encephalitis surveillance, acute encephalitis syndrome. All patients with febrile illness and altered behavior should be investigated promptly for viral encephalitis. Patients suspected need a lumbar puncture as soon as possible. Imaging is not required before LP unless a specific contraindication is present. Thank you for patience hearing and giving me the opportunity. Thank you.
Very well done, Dr. Pooja, and you have covered it in a vast topic within time limit. Delayed diagnosis of encephalitis is the theme of 2024 Encephalitis Day this year. Dr. Prachi Rastogi is from IIP Nagpur, and let us learn management of encephalopathy and encephalitis from her. Dr. Sachi Rastogi?
Yes, ma'am.
Yeah. Till that time,
Yes.
you share the screen. I would like that in this Encephalitis Day, social media hashtag Red for Wed is the theme this year. So we are actually, Manjusha madam and me, myself are carrying this theme this year.
Red.
Yeah.
Okay, ma'am, shall I start?
Yeah,
Hello.
you can start. You can start. Sanchi, you can start.
Okay, ma'am. Good evening, everyone. Today I'm going to present management of encephalitis and encephalopathy in children. So management includes 5 major steps. First is rapid assessment and stabilization. Next comes the detailed history and examination. Then comes the workup of the patient. After that comes the supportive treatment and definitive care. So initially, first we have to assess the patient and we have to maintain airway, breathing and circulation. So intubation is required if the patient has GCS less than 8, there is an impaired gag reflex, there is any abnormal respiratory pattern, or there are signs of raised ICP. Oxygen saturation less than 92% despite high flow oxygen, or the child is having fluid refractory shock. After that, establish an IV access and take initial samples, which includes a complete blood count, blood sugar, renal function test, liver function test, blood ammonia, electrolytes, blood gases, lactate, peripheral smear for malaria, and rapid test for malarial parasite, and serology for viruses. Fluid boluses are required if the patient has circulatory failure, or if inotropes are required, that has to be given. It is important to assess child's neurological function through a Glasgow Coma scale and identify any signs of cerebral herniation or raised ICP. It is important to examine the patient head to toe so that any important signs like any rash should not be missed, which can be a clue to etiological diagnosis. Nasogastric or oral tube placement is important in patients with altered mental status. Most of these patients of encephalitis or encephalopathy present in active seizures. So we have to give initial benzodiazepines, which are short acting, like lorazepam at the dose of 0.1 milligram per kg, or midazolam from 0.1 to 0.2 milligram per kg, followed by loading dose of first line anticonvulsant, which includes fosphenytoin or levetiracetam in the required doses, followed by maintenance doses of the same. After that, it is important to assess whether the patients required intensive care monitoring or not. So it is important to know the detailed history and examination, which is already covered by previous speakers. So I'm going to skip that. So if a patient of suspected encephalitis comes to you, after initial stabilization and blood investigations, 2 important investigations needs to be done. First is CSF examination and other is neuroimaging. For CSF examination, routine examination and culture along with biofires give you a etiological clue about the infective etiology. And if the patient, if NMDA or autoimmune encephalitis is suspected, then autoimmune panel needs to be done. Neuroimaging, MRI is the gold standard for all patients of encephalitis and encephalopathy. But in certain cases where LP is contraindicated, upfront CT should be done. So MRI findings can give a clue to diagnosis, which includes infective, autoimmune encephalitis, edema, and other encephalopathy like mitochondrial encephalopathy or metabolic encephalopathy. So initial investigation, apart from blood examination, includes a CSF examination in which color of the CSF, complete count and differential counts, protein, sugar, blood sugar, gram staining and culture, JE, IgM antibodies if it is suspected, HSV, PCR, CSF biofires, and CSF autoimmune panel in suspected cases. What information can be gathered from a routine lumbar puncture examination? A normal CSF it has a clear color. It has less than 5 cells and all are lymphocytes. CSF to plasma glucose is around 50 to 66%, and protein is less than 0.45. In bacterial infection, cells will be very high, color will be cloudy, and the counts will be mainly neutrophils. Apart from that, there will be low glucose and high protein. In viral encephalitis, cells will be moderately high, but differential will be mainly lymphocytes. Glucose will be normal and protein will be moderately high. In tuberculosis, the main point is that protein is very high and sugars are low, and differential count is mainly lymphocytes with moderately high cell count. In fungal, generally the cells are normal to high and differential is lymphocytes, but the glucose is low and protein is moderately high. CSF biofire should be considered in patients where routine examination of CSF is not able to give a clear picture. CSF biofire is a multi-phase PCR test which targets 14 microorganisms. It has a good sensitivity of 94.2% and specificity of 97.7%. If financial issues are there or accessibility is not there, then only HSV PCR can be done, which is 96 to 98% sensitive and 94 to 99% specific, since HSV is one of the common cause of encephalitis. Apart from that, if suspected, JE PCR should be done, which is 95% sensitive and specific. So, which patient should undergo LP CT scan before lumbar puncture examination? All the patients who have any focal neurological signs, who have uncontrolled seizures, any abnormal posturing suggesting raised IPP or herniation, severe alteration of mental status with a GCS of less than 10 and papilledema on fundus examination. Other than that, MRI is considered the gold standard. So there are typical MRI findings which can help you in the etiological diagnosis. For example, in herpes encephalitis, there are abnormal signal intensity in medial temporal lobes, cingulate gyrus, and orbital surface of frontal lobes. In Japanese encephalitis patients, there are signal intensities in thalami, substantia nigra, and basal ganglia. Tubercular meningitis has basal exudates as pathognomic feature of TBM. In varicella encephalitis, generally multifocal abnormalities are present. In cortex, there is associated cerebralitis, vasculitis, and vasculopathy. In Adam patients, multifocal abnormalities are seen in subcortical white matter, thalami, basal ganglia, and brainstem. In cases of autoimmune encephalitis, there can be some non-specific T2 hyperintense signals, or MRI can also be normal. So after initial investigation, it is important to give supportive care. Maintenance intravenous fluid should be started, which should be isotonic in case of, along with sodium monitoring. In case of suspected SIDH, fluid restriction is required to 2/3 of the maintenance. If patient has signs of raised ICP, first year measures should be started, like head and elevation, head and midline, minimum stimulation of the patient, and control of fever and seizures. Apart from that, osmolytic therapy, mannitol at the dose of 0.25 gram per kg bolus, followed by 0.25 gram per kg every 6 hours up to 48 hours. Or some people prefer hypertonic saline at the dose of 0.1 to 1 ml per kg per hour with a target sodium of 145 to 155 milliequivalent per liter. Maintenance of euglycemia is important in such patients to prevent hypoglycemia. Most of these patients have seizures, so after giving short-acting benzodiazepines, loading and maintenance of first-line anticonvulsants, and if required, second-line anticonvulsants is done. Some of these patients may have non-convulsive status epilepticus. In those patients, continuous EEG monitoring might be required. Empirically, all these patients should be started on a broad-spectrum antibiotic, which includes cefotaxime or ceftriaxone. For babies less than 1 month, injection cefotaxime is preferred at the dose of 150 to 100 milligram per kg per day in 4 divided doses. For more than one month of age, injection ceftriaxone is given at the dose of 100 milligram per kg per day, twice daily. This can be stopped if there is no evidence of bacterial meningitis. Acyclovir should be started in all cases of sporadic viral encephalitis. It should be stopped if an alternative diagnosis is made or HSV PCR in the CSF is negative and MRI is negative for HSV. For kids less than 12 years, it should be given in the doses of 500 milligram per meter square 8 hourly. And for above 12 years, it should be given at the dose of 10 milligram per kg 8 hourly for 21 days. In cases of suspected strep typhus encephalitis, doxycycline is the treatment of choice. Alternatively, injection azithromycin can also be given. For patients where cerebral malaria is suspected, artesunate is the drug of choice with a loading dose of 2.4 milligram per kg and followed by maintenance dose of 1.2 milligram per kg after 12 and 24 hours, and then maintenance dose of 1.2 milligram per kg per day for 7 to 10 days. Steroids are important, especially in the cases of ADEM and autoimmune encephalitis. First, methylprednisolone is given at the dose of 30 milligram per kg for 5 days with a maximum of 1 gram per day. Low-dose prednisolone should be started after IV pulse therapy over 4 to 6 weeks in ADEM and longer in the patients of autoimmune encephalitis. Oral prednisolone or dexamethasone should be given to CNS tuberculosis patient for 4 weeks and tapered over 4 weeks. IV dexamethasone at the dose of 0.15 milligram per kg per dose every 6 hours for 2 days is given in cases of acute bacterial meningitis. IV immunoglobulin is the treatment of choice for patient of autoimmune encephalitis where NMG or autoimmune panel is positive. So it is given at the dose of 2 gram per kg over 2 to 5 days. Alternatively, plasmapheresis, if it's available, is a good option. 5 to 7 cycles can be given every alternate day. Second line of management for autoimmune encephalitis is rituximab. It's a monoclonal antibody inhibition. Inhibits CD20. It is given at the dose of 375 milligram per meter square weekly for 4 weeks. Or cyclophosphamide can also be given at the dose of 750 milligram per meter square monthly for 3 to 6 months. We can alternatively, if these won't work, then we can start tocilizumab or interleukin-2. For maintenance therapy, steroid-sparing agents like azathioprine or MMF are used in certain cases. Apart from this, patient care is of utmost importance. Change position every few hours to prevent bed sores. Use of water or airbed in long-term patients. Physiotherapy to prevent spasticity. Medicines like baclofen and trihexyphenidyl also prevent spasticity and dystonia. Parental counseling is must in such cases. Coming to prognosis and sequelae, outcome depends on etiology, patient's age, severity, and promptness of treatment. In viral encephalitis, outcome may range from complete recovery to neurological sequelae and severe neurological deficit. Mortality with HSV patient is found to be 20% and with Japanese encephalitis patient to around 30%. So the take-home message is early stabilization and prompt management is the cornerstone of treatment of encephalitis. Prognosis depends upon the etiology, age, and severity of presentation. Systematic protocol-based investigations and management prevents morbidity in such patients. Collaboration with the intensive care team is of utmost importance to get good results in such patients. Thank you for the patient hearing.
Thank you, Sachi. Such a vast topic covered very well. And I now request Dr. Chandana Bhagwat Madam to give her expert comments. Dr. Chandana Bhagwat, madam.
Yes. So, Dr. Pooja and Dr. Sachi have very well covered the topic in their crisp and informative presentation. So, I just wanted to highlight a few topics. So, basically, whenever a child presents with encephalitis or fever with neurologic symptoms, there can be a myriad of differential diagnosis. So, only with a thorough history, examination, and judicious use of investigations and their interpretation can help us in cinching the diagnosis. Neuroimaging neuroimaging must be done with a contrast, either a CT contrast or an MRI with contrast as per the indications that were discussed. But a contrast imaging is must when we are suspecting an infectious etiology in a child. Also, in herpes simplex encephalitis, sometimes when the LP is done in the very initial stages of the infection, even less than 72 hours of the onset of signs and symptoms, the CSF, HSV, DNA, PCR may come negative. So, if there are strong clinical signs and symptoms that a child is suffering from herpes, then even if DNA PCR is negative, a second DNA PCR can be done to confirm the diagnosis. Also, a child with encephalitis, neurological management as well as critical care management is of utmost importance. So we have seen many a times these childs succumbing and worsening secondary to fluid and electrolyte imbalances, improper ventilation, oxygenation, and hospital-acquired infection. So a PICU management is of utmost importance in these children. Thank you.
Thank you, Dr. Chandana Bhagwat, madam. Dr. Anand Diwan, sir, do you want to comment?
Not much. I think everything was extensively covered, and even Dr. Bhagwat's comments were appropriate and most
There was
clinical.
There is one question in the chat box. Can allergies cause headache?
Before that, just to add points in encephalitis and viral or bacterial meningoencephalitis, before first antibiotic dose, the steroid dose should be given at least half an hour before. That is very important. And if there are some focal signs and if CSF is not immediately possible, then the blood culture to be sent and we can start the antibiotic, because after starting antibiotics, the CSF culture may change. So blood culture can be of benefit if the CSF is getting delayed. Another question from the...
There is one question in the chat box. Can allergies cause headache?
Causing fever, yes. Only per se allergy, don't know, means the medicines causing allergy can give rise to headache also, or what kind of allergy means it's recurrent insults or like angioneurotic edema or something like that, then it can cause the fluid accumulation and can cause a headache. But apart from that, first episode of some allergic drug reaction, headache, I have not come across any.
Dr. Nityanand.
Question by Dr. Sanjay Shah. Why steroids in a confirmed case of acute bacterial meningitis?
I said before giving first dose of antibiotic, because that is going to cause a lot of inflammatory reaction and the sequelae to that, usually sensorineural hearing deafness or some other strokes.
So I will also like to add a point. So steroids are a double-edged sword. We have to give them before giving antibiotics in the initial 6 hours. When a child presents to us in that time, we are not sure of the diagnosis, whether it is a viral encephalitis or it is a bacterial meningitis. Investigations take time for us to get lab results. So steroids, they are definitely not indicated in viral encephalitis. For bacterial encephalitis, there was a recent Cochrane review which was done, and they had showed that in developed countries, giving steroids prior to antibiotics reduce the morbidity, such as hearing loss. But there was no, it will subsequently say that it is a double-edged sword. When you are unsure of the diagnosis, when a child has just landed, giving steroids it has to be by the clinician's perspective.
Most of the times, the etiology we are not knowing. So at the day one or immediately after admission, it's our empiric therapy which combines everything, antiviral, antibacterial, and as the results come, then we stop either antiviral or antibacterial depending upon the result. So initially, I think we start with the polytherapy, and I think their steroid also is required, and then we can subsequently stop.
So the message is clear. Dr. Nityanand wants to have his comment. Dr. Nityanand, sir, you can unmute and ask your question.
Pallavi, unmute him. Pallavi.
Pallavi, madam, can you please unmute Dr. Nityanand?
Yes, ma'am. Ma'am, his audio is not connected.
Okay. Any other question?
Amongst the audience, anyone who want to ask any question, please unmute yourself and you may ask or raise your hand.
One more question
Hello.
also is there in chat box.
Hello.
Can HDM?
Yeah.
Hi, yes, please.
Sanjay Shah, sir.
Yeah. In a case of bacterial meningitis, as it was mentioned in the slide that the steroid should be given for 2 days, whereas one of the speakers said that just one shot of steroid before starting the antibiotic. So I'm a little confused about role of steroids in bacterial meningitis.
No, give it for 2 days, but the first dose should be given before the first dose of antibiotic. Then it
So
serves the
Nelson
purpose.
mentions 2 days only, but as sir said that the first dose should be at least 30 minutes before the first dose of antibiotic.
Okay, fine. And it can be safely given for 2 days.
Yes.
Without any
If it's a bacterial H influenza, yes.
Yeah.
Diti Ingale, I think it's the same thing what she's asking. Only one dose of steroids pending CSF, or we continue for 3 days after the report along with the antibiotics.
No, so 2 days, 6 hourly you have to give for 2 days. 0.15 milligram per kg per dose.
Japanese encephalitis diagnostic test and specific features to differentiate from others. Kindly comment. Dr. Virendra Desale.
Dr. Chandana?
So, does Sachi wants to answer this, or otherwise I will answer?
Ma'am, you can answer.
Yeah. So, basically, Japanese encephalitis affects the basal ganglia and the thalamus. So, the child will have predominantly extrapyramidal features such as rigidity and dystonia, along with the fever, altered sensorium, and other symptoms of encephalitis. Also, we can do CSF, Japanese encephalitis, PCR, CSF, IgM antibodies also to confirm microbiologically.
Can HDMs, allergens, pollens, and fungi allergens cause house dust mite allergens, pollens, and fungi allergens cause migraines? Question by Dr. Sandeep Vasankar. Any one of you could take it, Chandana madam or Divan sir.
Triggers can be anything. If the exposure to same environment, same dust mite is giving rise to headache, then I will consider that as a significant trigger, and then just avoiding that trigger is good enough to prevent the migraine headache. Only if it is causing recurrent exposure and giving rise to headache. Otherwise, one exposure will not.
Sir, we are not able to hear your voice.
No, you are not audible. Dr. Jayashree, one more question is there.
Yeah, there is one more question. How many days we should consider giving 3% NaCS or mannitol in the case of cerebral edema? Dr. Sumit Lamge has asked this question. Madam Chandana, madam, can you take this question?
Yes. So there are no clear-cut guidelines as to how many days we have to give, but they are indicated in acute raised ICP. So, the usual notion is that we start the child with antibiotics and anti-raised ICP measures. In the next 72 hours, as the antibiotics takes place and as per the clinical improvement, we can stop. But there is no cutoff as to the days for which we can give. For chronic raised ICP, 3% NaCl has not that use as compared to in acute raised ICP, but we can give safely for 3-4 days and wait for our antibiotics and our antivirals to work.
Is there any specific
symptomatic
features
therapy.
of amoebic encephalitis? A question asked by Dr. Pradeep Satonkar. Madam, amoebic encephalitis, any specific features? Hello, Chandra. Madam. Yeah.
Yes. So, amoebic encephalitis is sir asking about primary amoebic encephalitis, the PAM or the GAE spectrum. So, there are not many specific features, only some history pointers such as contact to the river bodies is one thing that we can consider. Apart from that, as per my knowledge, there is no specific diagnostic feature that we can distinguish these etiologies from.
So as per Dr. Amdekar's guidance, we have to ask the history. There is another question by Dr. Sanjay Shah sir. What is the cost of CSF BioFire test?
So actually CSF BioFires is expensive. It costs around 16,000 rupees. So that's why I mentioned that if patient is affordability is an issue, then only HSV PCR costs around 6,000 rupees.
Just to add on, Chandana madam, when we use 3% NaCl or as in cerebral edema measures, do we monitor it with the CT scan or we go clinically? If facilities
No, we
available.
don't monitor it with CT scan. Only if the child is worsening, there is a need of a repeat neuroimaging, or if there is no improvement in the next 24 to 48 hours, then we can repeat a neuroimaging. If we are sure that we are giving antiviral, antimicrobial, and expected clinical improvement is not taking place, then we can repeat a neuroimaging to see whether some complication has developed, like brain abscess, subdural empyema. But only for raised ICP, there is no indication that we repeat neuroimaging multiple times. The best method to monitor raised ICP is putting a ICP catheter, which is not possible in most of the clinical settings. So we have to go clinically.
Indirect way to monitor is electrolytes. You can just see whether whatever desired hypernatremia is achieved with the mannitol or 3% NaCl. Otherwise, it's all clinical. It's like a symptomatic therapy. When the signs of raised ICP is there, the mannitol or 3% NaCl should be continued. Once the signs are less, then we can taper it or stop.
Given a choice between the two, which would be the preferred one?
I prefer mannitol.
So I will like to add on the CSF BioFires test also. So the other cheaper option is sending the samples to the National Virology Lab, which is in Pune in NIV, which does free of cost. And 4 viruses are covered: Japanese encephalitis, herpes simplex virus, Chandipura virus, and dengue virus. So that is another option. Only the courier charges apply. For government institutions, as far as I'm aware, it is free. And even for private, it is free.
And how much duration would we be getting the report?
It takes 3-4 days. 4-5 days it takes.
I think there are no more questions.
There is a comment from Dr. Nilofer that in Japanese encephalitis, it will be a vaccine and waning phenomena which is observed.
There is one more question: comparative efficacy of migraine prophylactic drugs.
That week, there is no head-to-head trial. But ones are cyproheptadine, beta blockers like cephalosporin.
Sir, your sound is not clear.
No head-to-head trials, but the preferred choices in pediatric population is cyproheptadine, the flunarizine or sibelium, the calcium channel blocker, beta blocker like a propranolol or topiramate. When compared to placebo, each drug has been compared with the placebo, and it has shown it's not very great compared to the placebo. So all has a efficacy around 30-40%. Even the placebo has shown 30-40% benefits. So it's really a debate whether the prophylaxis really works or not. But in our practice, when we are prescribing patients taking the prophylaxis and those who are not taking medication, we clearly see that it is helpful. So, all in the range of 30-40% efficacy. But the drug we choose depends on other comorbid conditions like obesity, skin, or other depression. Depending upon that, we choose the prophylaxis.
Yes. There are no more questions now, and the vast topic is covered very well in this session. We could not have received a better prasadam on this Ram Navami, a prasadam of knowledge. I thank our expert, Dr. Anand Diwan sir, and our another expert, Dr. Chandana Bhagwat madam, our MMC observer, Dr. Prashant Badane sir, our own Maha-AP Chair President, Dr. Ram Gopal sir, our Secretary and Joint National Coordinator of IAP Presidential Action Plan Committee, Dr. Amol Pawar sir, our all Beauty with Brains, our own chairpersons of Women Committee, Dr. Manjusha Sherkar madam, co-chairperson Dr. Grivita Raikar madam, and convener Dr. Amruta Vaviskar madam. The most important, and I thank all the audience for the patient hearing and happy learning. Thank you so much.
Congratulations all the speakers.